Hello, everyone. Can you guys hear me? If you can, please just write it in the chat box. If you guys can hear me and you can see the screen, and we'll just start from there. Okay, great. Great. Awesome. Awesome. All right, let's get started. Okay, let's get started now. All right, we're going to start with signaling pathway of the endocrine hormones. Although this looks low yield, but it is not. It's very high yield. Because it's simple yet important. Okay, so let's just get started. The first one we have is cyclic AMP. And if you just recall, how do we get, first of all, we got to go back, right? How do we get cyclic AMP in the first place? So if you recall, you have a GS and GIs, right? GIs, GS would stimulate adenylate cyclase, right? And that will stimulate the conversion of ATP into cyclic AMP, right? So GS stimulation is going to get you cyclic AMP, adenylate cyclase stimulation, cyclic AMP. Now, cyclic AMP, which they haven't mentioned here, but they most likely would ask, will further go ahead and do the stimulation of protein kinase A, so PKA. And that PKA will lead to further actions. Now, if you just think about it, all you are seeing here is all the A's. So A, cyclic AMP, PKA. Okay, that's just the signaling pathway here. Now let's see which hormones work through the cyclic AMP. So the hormones are a lot of hormones like FSH, LH, ACTH, MSH, TSH. Wait, actually, let's put CRH as well here. TRH, ACG, ADH, all of that. So the mnemonic they have is called flat, champs, chug. You want to remember that? That's great. But if you just want to know, okay, some hormones, about almost all hormones we're looking at, look, FSH, LH, ACTH, MSH, and CRH, beta ACG, TSH, and ADH. Don't you see almost everything is coming from anterior pituitary, posterior pituitary, except some like oxytocin, except some like ADH1 receptor. So you can just think about it that way, or you could memorize this, whichever way you like. But most important, let's talk about not which ones are high yield to look into this. So PTH is high yield here, works through cyclic AMP. Calcitonin works through cyclic AMP, high yield. Glucagon here, high yield, works through cyclic AMP. These three are high yield. Others are also high yield, but remember, all are coming from your one is coming from hypothalamus, and this also is coming from hypothalamus, and the rest is just anterior pituitary. Posterior pituitary, all you have is the ADH-V2 because oxytocin and the ADH that is working on V1 will work through IP3. Okay, let's look at the next one. That's the cyclic GMP now. Cyclic GMP is going to, the hormones that are going to work through it are also very simple if you think about it. You have the BNPs, ANPs coming from heart, from the ANP from the atria, BNP from ventricles, and you also have nitric oxide, NO, that is all going to work through cyclic GMP. And the mnemonic here is bad grandpa. Okay, bad grandpa works through that's so BAD and grandpa GMP. So all are they doing? They're just doing vasodilation. If you want to remember this mnemonic, you could, but just if you know that, okay, whatever is doing vasodilation, especially your NO, ANP, BNPs, that's cyclic GMP. Okay, then the other one now is the IP3. IP3 is, so if this was GS, right? So IP3 is going to work through GQ couple receptor. So GQ would stimulate the phospholipase C, if you recall, right? Phospholipase C. And that would eventually stimulate your IP3. And one more thing called DAG. And those are going to stimulate your protein kinase C. So here, what is important is all the C's. For example, let me take just take a look here. You have a C, you have a phospholipase C, and on cyclic AMP was all about A's, adenylate cyclase protein kinase A. When they talk about protein kinase C, right away you're going to think IP3 pathway, GQ couple receptors. When they talk about protein kinase A, you will think about GS couple receptors. Now let's talk about the actual hormones that are going to work through these. So you have a GnRH, this is exception from the anterior pituitary hormones, right? Oxytocin, ADH, TRH coming from hypothalamus, histamine, and angiotensin 2, gastrin. So these are the ones that go through IP3. The mnemonic that you have here is called GO-TAG. If you're into mnemonics, you could do this. The other one is going to be intracellular receptors. One thing they will ask you, these intracellular, what are they? Well, that's the zinc finger receptors. Zinc finger receptors intracellularly. Okay. So the hormones that work through these are progesterone, estrogen, testosterone, cortisol. So what is common in all of this? So these are all steroid hormones. So all steroids have intracellular receptor. Okay. Aldosterone as well. Now, if you look at this one now, aldosterone, T3, T4, vitamin D, these are also steroid receptors. They also have intracellular receptors. They work like steroid. One thing they haven't mentioned is also vitamin A. Vitamin A also works as steroid, or it's something they can mention as retinoic acid. Okay. So these all are going to work through steroids. When you think about intracellular receptors, like intracellular, a receptor within a cell, you're going to think about steroid, progesterone, estrogen, testosterone, cortisol. That makes sense, right? These all are steroids. But when you think about aldosterone, I mean, might be the mind doesn't go there. So aldosterone, think about aldosterone, T3, T4, vitamin D, vitamin A. They're all like steroid. They work through steroids, work like steroid receptors. And the good point about these, let's just take a look that how they, these steroids, these steroid receptors, they diffuse from the cell membrane and they go into the cell. And in the cell, they have their own specific, they have these zinc finger receptors or their own receptor known as sometimes, let's say for cortisol, you have something known as heat shock protein receptor, HSP receptor. So when you have these receptors, this, let's say this is cortisol, it binds to this receptor. When it binds to the receptor, and that leads to dimerization of cortisol, and then it goes into the nucleus, and in the nucleus it directly binds the DNA. Okay, and then from DNA it's going to start making the reaction. So there'll be formation of mRNAs, and then transcription, and everything will go forward from there. But the important point is they diffuse through the cell membrane without anything. Okay, so that is important for steroids. The next is receptor tyrosine kinase, high yield. We did talk about a lot. Receptor tyrosine kinase for insulin. So receptor tyrosine kinase, it has insulin. So insulin works through tyrosine kinase. So here IGF-1, insulin-like growth factor, right? So as the name suggests, so I guess with the name you can say, okay, it's insulin-like growth factor. So why not it should work just like insulin? Yes, it's going to work like insulin. This is high yield. This and this. And the rest is just you have the FGFs, PDGFs, and EGFs. Okay. Other than that, the mnemonic here is called MAP. What is this? MAP kinase pathway. Get found in the MAP. Okay. Then you have this non-receptor tyrosine kinase. So you had a receptor tyrosine kinase. Now you have a non-receptor tyrosine kinase. These are going to be your prolactin, high yield, your immunomodulators, for example, cytokines, IL-2, IL-6, IFN, and growth hormone. Okay. And you're also CSF, CSFs, erythropoietin, thrombopoietin, and all of them. What is important in this? Well, high yield is your erythropoietin, okay, and that it works through non-receptor, high yield non-receptor tyrosine kinase, because this receptor tyrosine kinase has an activity called intrinsic tyrosine kinase activity. Intrinsic tyrosine kinase activity. Okay. So these are non-receptor tyrosine kinase, which are erythropoietin, prolactin, and your growth hormone. Okay. They work through which pathway? JAK-STAT pathway. And the tyrosine is working through MAP kinase pathway, right? And the mnemonic is get a jacked pig. If you are into mnemonics, for sure, you could go with that. But yeah, that's pretty much what we have. Same thing, similar. We talked about the steroid hormone, how the signaling pathway works for steroid hormones. So there is a hormone which binds to the receptor located in the nucleus, or could be in the cytoplasm, not on the cell surface. So it just goes in, binds to the receptor either within the cytoplasm or within the nucleus itself. Okay, the transformation of receptor to exposed DNA binding protein. When this steroid binds to the receptor, takes it in, there's an exposure to the DNA binding protein, and then that receptor binds to that DNA and leads to formation of pre-mRNA, mRNA, and then synthesis of proteins or whatever the further action they're going for. Okay, one thing similar to this is called epinephrine. Let's talk about that. Epinephrine has a surface receptor, so surface receptor epinephrine. Let's just mention it here. Okay, so epinephrine comes and binds to this receptor on the cell surface. Now the difference here is this transmembrane surface receptor then activates the second messenger, which is total normal in everything we see, which activates the second messenger, and then it goes into transcription factors, and it goes through activation of the gene within the DNA itself. Okay, that's also a little bit to think of. Steroid hormones, you have to know this. Okay, which are steroid hormones? So with these, you can just think of these are all steroid hormones. Yes, but with the aldosterone, T3, T4, vitamin D, the mind not always go there, but remember, thyroid hormone is a steroid hormone. Aldosterone, vitamin D, vitamin A, all work like aldosterone, work like steroid. Okay, now important point on the right side is that steroid hormones are lipophilic. Therefore, they must circulate bound to specific protein, specific binding globulin, uh, which increase their solubility. In males, increase in sex hormone binding globulin, SHBG, lowers the free testosterone, leads to gynecomastia. We did talk about it in prolactin, that whenever you have more testosterone bound to its sex hormone binding globulin, there is less free testosterone. That means that it's going to cause increase in estrogen to testosterone ratio, which leads to gynecomastia in males. Okay, that's in males. Now in females, if you were to decrease that sex hormone binding globulin, that is going to raise that free testosterone, and in females, going to give you hirsutism, right? So again, same thing. Here, all we had is increased sex hormone binding globulin, right? That would bind testosterons. Now, when we have decreased sex hormone binding globulins, more free testosterone will be available, and that is going to cause hirsutism in females, right? And the last thing is with estrogen. When you increase the estrogen, for example, in OCPs, for example, in pregnancy, it's going to cause increase in sex hormone binding globulin high yield. That when you give someone an OCP or they're pregnant, their sex hormone binding globulin increases. Okay, that's also important. And I think this is also going to come in thyroid somewhere. Okay, then what else we might have? Okay, let's talk about simple one more thing here, since we were talking about all the receptors, is about the diffusion. So let's just do it here like this. So we have something known as you know, that there was a simple diffusion, facilitated diffusion, and active transport, right? So let's just say required energy, like ATP, for example. Here is no, here is yes. They require and they don't require. Do they require the transport protein? Yes and no. So which, and this is the transport across the membrane. So which ones? So for example, if you talk about simple diffusion, they don't need any energy. They don't need any transport because they're simple diffusion. They will diffuse simply. They don't need anything. Now with the facilitated diffusion, what these guys need, they need the transport protein. If you look, this is yes. So they need the transport protein, but they do not need energy. Now, when you think about active transport requires energy. On top of that, requires the transport protein. Okay, that's just there. So yeah, that's pretty much what we have. Let's just quickly go through this page and move on to next. Okay, cyclic AMP, almost all anterior pituitary, posterior pituitary hormone. What you really have to know: PTH, calcitonin, glucagon. Okay, cyclic GMP is all about vasodilation, BNP and PNO. IP3 is all about the rest of anterior pituitary. You can think about GnRH, oxytocin, ADH. On top of that, you can think about, okay, angiotensin 2, histamine, intracellular high yield, all steroids with T3, T4, DNA, vitamin DNA, and aldosterone. Receptor tyrosine kinase, you should know insulin, IGF-1. Okay, they have intrinsic tyrosine kinase activity. Okay, with the non-receptor tyrosine kinase, all you got to know about erythropoietin, your prolactin, and growth hormone. And that's going to be all. One high yield again here. If in males, if you have low, let me use the pen here. If you have low free testosterone, then you are going to go into gynecomastia. In females, if you have high free testosterone, you are going to go into hirsutism. And why would you have low or high testosterone? It all depends upon sex hormone binding globulin. If you have normally testosterone binds to sex hormone binding globulins. So if you have a higher SHBGs, more testosterone than a bone, less free testosterone. If you have lower, vice versa. Okay. And that's pretty much all we have. Let's move on to the next. Here, very important is called, now we are going into the pathology section. The first thing we are going to talk about is syndrome of inappropriate ADH secretion. Okay. With this, it is characterized by excessive free water retention, euvolemic hyponatremia with continued urinary sodium excretion, urinary osmolality greater than serum osmolality. Okay, so one thing that you have to know that when we think about, as first of all, you got to know the definitions, right? So when you think about SIADH, what do you think of? Well, you think of simple. You know, the names are complicated, but things are very simple. But you got to know what they are, right? So it is just think about it as there is increase in ADH. There's an increase in ADH. So let's take a look again. Syndrome of inappropriately high ADH levels. Okay, and that is going to cause. Let's take a look at this picture first. So you have ADH. ADH, which is stored in the posterior pituitary, goes into the blood. SIDH, which is now known as SIDH, a lot of ADH is going there. So syndrome of inappropriate ADH secretion, a lot of ADH has been secreted. Okay, that excessive ADH is going to cause its normal physiological actions, but now because it's in axis, that's going to look in pathology, right? So what you are going to get is so it's going to go to the medullary collecting ducts, put on those aquaporin channels, and will cause water retention. Water retention. That water retention is going to do what? Okay, when you have that water retention, that the body will have an increased amount of water. Right. Let me just write this down here. Increased total body water. Right. And that increased total body water is going to do a couple things. So the first thing, well, I think let's just zoom in and write this down here. Because if you understand this chart that I'm going to draw, you understand everything. So SIADH, water retention. Water retention leading to increase in total body water, right? That increased total body water is going to do a couple things. First of all, it's going to cause ECF expansion, extracellular fluid expansion, right? And on the other hand, it's going to cause, because you have a lot of water, it's going to cause hyponatremia, right? Natremia meaning sodium level is going to go down, but it's, if you think about it, it's not going down. It's just that you're having a lot of free water that you think the sodium is low. So it's called dilutional hyponatremia. Dilutional, that you have diluted the serum so much that it looks like that you're hyponatremia, but you're not in hyponatremia, because why would you have hyponatremia when you didn't lose any sodium, right? So it's called dilutional hyponatremia. Hyponatremia. Okay, so this dilutional hyponatremia, and you have extracellular fluid expansion. First of all, let's talk about the fluid expansion. ECF expansion, volume expansion, is going to decrease your aldosterone levels, and it's going, because it's that high fluid overload is going to go into the heart. The whole volume is going to be high, so heart is going to release ANPs and BNPs. So increase in ANP plus increase in BNP. And that increase in BNP will eventually, what they are going to cause, they will say, hey, we think we got so much fluid, let's just throw it out. So the way that they throw out fluid is by increasing urinary sodium excretion. As you remember, the sodium follow wherever sodium goes, water follows, right? So what they will try to do is they will throw out. So let me just write it here: increased urinary sodium excretion. Okay, and that is going to cause a couple things now since you are now throwing out sodium, that is going to get you into the sodium loss, one thing. But on a positive note, what they are going to cause is normalization of your ECF, extracellular fluid volume, will be normalized. Okay, and that, so with the sodium loss and normalization of your extracellular fluid volume, you are going to cause euvolumic hyponatremia. Hyponatremia. Okay. Okay, now with this, let's read and we will come back here to this chart whenever there is something that we need to understand, okay? So it is, again, it is characterized by excessive free water retention. Here's the first point we talk about is excessive free water retention. That is going to cause euvolumic hyponatremia. Euvolumic hyponatremia with continued urinary sodium excretion. Continued urinary sodium excretion. Urine osmolality will increase greater than the serum osmolality. Right? When you ask why. So when you increase the urinary sodium excretion, okay, that means, let's say this is urine. Here you're causing more and more sodium to go into excretion. It's going to raise its osmolality, simple as that. And because where is the sodium coming from? It's coming from serum, right? So because the sodium is going from serum into the urine, you're essentially decreasing serum osmolality and increasing urinary osmolality, right? So you're causing an increase urinary sodium excretion, which leads to increase in urinary sodium excretion. Because you're losing sodium in urine, so of course you're going to cause increased osmolality in urine, right? So that's exactly what I mentioned there. Next point is body is going to respond, which we did talk about. Body responds to free water retention with decreased aldosterone, and increase in ANP, BNP, increase in ANP, BNP, causing increase in sodium secretion. Again, increase urinary sodium secretion, which is again this point. Normalization of extracellular fluid volume. You are normalizing the ECF volume, causing euvolumic hyponatremia, right? Now let's talk about the treatment now. So this is all the pathology. Okay. Now the treatment, let's change in color. Treatment is going to be, you want to go for fluid restriction, first line, salt tablets, IV, hypertonic saline, diuretics, ADH antagonists. Example, what is it? Conivaptan, right? Let me make sure. Yeah, conivaptan or tolvaptan, or demiclocycline. So these are all the drugs that you can give to these patients as a treatment. Now, here is some mnemonic for easy recalling. SIADH causes include healed up water. So why, the question is, why would you have SIADH in the first place? Why would you have increase in SIADH, basically increase in ADH levels? Why? And the reason why could be any of this, right? You could have a head trauma, CNS disorder, ectopic ADH secretion from the small cell lung cancer, exogenous hormone, for example, vasopressin you get from outside, desmopressin or oxytocin, lung disease, drugs like SSRIs, carbamazepine, cyclophosphamide. All of them can essentially cause increased level of ADH. And for sure, they got to tell you this when they talk about ADH, right? History is going to be important. History about head trauma, ectopic ADH small cell carcinoma, exogenously taking some hormone, lung disease, some other medication like SSRI, carbamazepine, cyclophosphamide. All of them are high yield, and then this is the pathology that you are going into. Okay, and that's going to be all for SIADH. Some important other points could be, as a summary, we have all you have to think about as a summary point that water retention has happened because of ADH, and that water retention is going to cause hypervolemia in the first place, increased total body water. But your hemostasis is going to start working. For example, that increase in body water will go to the heart, that volume expansion will release ANP, BNP. They will throw out the sodium and trying to have euvolemia. That's the main thing, euvolemia. So if you, in a question stem, for example, you will for sure see euvolemia, meaning the volume is going to be normal by the time you see it in the question stem, but high yield is going to be low sodium, and it's going to be low plasma osmolality. And they can also mention increased urine osmolality. So if you have some picture like this, you're going to think about SIADH or increase in ADH another way. Okay, so this was high ADH. So that's pretty much it. Now let's talk about something which is low ADH. Low ADH or ADH deficiency, right? So when you have a low ADH, what's going to happen is it's that because you don't have ADH, you cannot reabsorb the free water. So you will cause hypoosmotic volume contraction. Hypoosmotic volume contraction. Okay. And why is that? It is due to loss of sodium chloride with ECF depletion. So due to loss of sodium chloride with your extracellular fluid depletion. Because you cannot reabsorb water, that extracellular fluid will deplete, and that is going to cause the loss of your sodium and chloride, and that's what is going to give you hypoosmotic. Again, the word is hypoosmotic volume contraction. Okay, so in the labs, what you are going to see is going to be your, first of all, water depletion, so hypovolemia, increase in sodium, and increase in plasma osmolality, and decrease in urine osmolality. The opposite of whatever you have in increase in ADH is going to be with the ADH deficiency. Okay, and that is pretty much what we have. Okay, one last tie-in actually is very high yield is lithium. Okay, lithium, I don't know if they talk about it here or not, but let's just mention it here and then that did great. So lithium is going to inhibit, for example, ADH in kidney. So if lithium is going to inhibit in kidney, something known as nephrogenic DI you will see. So let's take a look at the whole scenario now. So here we have the primary polydipsia and diabetes insipidus, high yield. Okay, so primary polydipsia and DI, which is diabetes insipidus, it is characterized by production of large amounts of dilute urine. Again, what is DI? Diabetes insipidus, you have a low ADH. What is SIADH? You have high ADH. Okay, remember these terminologies, okay? So when you have a low ADH or PP, which is the primary polydipsia, they're both characterized by production of large amount of dilute urine plus minus thirst. Okay, so basically, calling it polydipsia, a lot of urine or polyuria. intense thirst, polydipsia, a lot of urination, polyuria. And it's going to cause what? Volume depletion, right? Volume depletion. And when you deplete the volume, you are basically when you deplete your extracellular fluid volume, the more sodium you will see. So it will be hypernatremia because you're losing free water, right? So let's read more now. Urine specific gravity will be less than 1.006. Urine osmolality usually less than 300. Why is it less? Because you're just putting so much water in the urine that you don't have increased osmolality of the urine, right? Central DI may be transient if the damage is below hypothalamic median eminence or in the posterior pituitary. ADH in hypothalamus can still be secreted systematically via portal capillaries in the median eminence. So this is a very high yield thing. All they're saying is, since ADH is formed where? In the hypothalamus, right? ADH is formed in the hypothalamus. And if you recall, it is stored in the posterior pituitary for further secretion. So they're saying if you have a damage below the hypothalamus, so let's say you have a damage here, anywhere, or in the median eminence, which is right here, or in the posterior pituitary right here, ADH in the hypothalamus can still be secreted. That ADH, because it is produced in the hypothalamus, it could still be secreted in via the portal capillaries in the median eminence, so you will not see deficiency. Okay, because it's not made anywhere here, it's made in there. But if you have a problem in hypothalamus, guess what? You will not be able to make ADH, right? So let's read now. Central DI, also known as arginine vasopressin deficiency, is the name for it. Okay. The next one is nephrogenic DI, also known as arginine vasopressin resistance. Okay. This is also important. Why is it important? Because first, it does not write anything extra. If they have mentioned arginine vasopressin deficiency, that means it is important that you have to know, okay, when we think about ADH, a new name we have to think about is arginine. Arginine. You already know vasopressin. Vasopressin is ADH. Deficiency is deficiency. No question about it. So arginine is a new name. Let's just say that. So when you have arginine deficiency, you will think about central DI because there is deficiency. But here in nephrogenic DI, it's called resistance because it is a resistance, and we will see how. So let's take a look at each one of the details. All right, the first thing we have is primary polydipsia. With the primary polydipsia, the definition here is that there is an excess water intake, as the name suggests. Polydipsia, intense thirst, that they will drink a lot of water. Excess water intake. Causes are your psychiatric illness, hypothalamic lesion affecting the thirst center. So either they have some problem, psychiatric illness, or their thirst center, there's a problem there, which is not letting them stop, or they don't have any regulation. So thirst center or psychiatric illness. Okay. Serum osmolality, because you are putting so much water in the extracellular fluid, that serum osmolality for sure is going to go down. ADH levels, for sure, either is going to be going down or normal, but think about it as low because you have more water inside. You don't need ADH to bring more water in because you already have a lot of water. Okay, if you were to restrict the water restriction test. So let's take a look at A first. What is water restriction? No water intake for about 2 to 3 hours, followed by the measurement of urine volume and osmolality, as well as plasma sodium concentration and osmolality. Okay, you don't take water in for 2 to 3 hours, and then you measure the levels. So if you were to have water restrictions, you will see there is a significant increase in urine osmolality. there's a significant increase in urine osmolality greater than 700. Okay. Desmopressin administration. What is again desmopressin? It's for the ADH, so we're not going to read in primary polydipsia. But anyways, this is ADH analog, as we talked about. It is administered if serum osmolality is greater than 295 to 300, and the plasma sodium is greater or equal to 145, or urine osmolality does not increase despite increase in plasma osmolality. We'll talk about ADH desmopressin when we talk about central DIs. But treatment is going to be water restriction, simple as that, because you're drinking more water from outside. All you got to do is restrict the water. You will be fine. Everything will be good. But you got to treat the disease, either psychiatric illness or either you look in the thorough center. Is everything okay with that? Okay. So now the second thing is all about your central DIs and nephrogenic DI. So you have a low ADH. Central means coming from the top, brain and everywhere else, posterior, right? And nephrogenic means working in the kidneys. So when you, by definition, the central is decrease ADH release. And by definition, nephrogenic is you have ADH in the bloodstream, but it is resistant, meaning it's not working on the kidneys itself. Okay. What are the causes for decreased ADH release from the top? You have idiopathic, we don't know the cause. Brain injury could lead to that. For example, trauma, hypoxia, tumor, surgery, infiltrative diseases. Okay, any disease of this sort can cause decreased release of ADH. And the nephrogenic resistance, why would you have resistance, right? It is resistance due to hereditary cause. For example, V2 receptor mutation. So ADH works on V2 receptors in the kidneys. There's a V1 receptor it works on, but that's only on the blood vessels. So here, when we talk about nephrogenic, we're talking about V2 receptor. Hereditary mutation in the V2 receptor is going to cause resistance because there is a mutation in that receptor where normally ADH works on. Now, because there's a mutation in that receptor, the ADH will not work on it. So no matter how much ADH you have, nothing will show, nothing will work. And that's going to come in handy when we talk about this treatment, because no matter how much from outside you give desmopressin, nothing is going to work. So we will give something else. We'll do something else for that. But here, hereditary V2 receptor mutation, drugs, for example, which can cause it, again, lithium, demiclocycline, they are all going to cause this ADH resistance by inhibiting the ADH receptors. Hypercalcemia and hyponatremia. Okay, so let's just write this down. Low sodium, potassium, and high calcium, and lithium, and this demiclocycline or hereditary mutation. All of them can cause nephrogenic DI. So what's going to happen is with these, both of them, you are going to have increase in serum osmolality. Increase in serum osmolality because you can't get, again, what was the normal? You got to know the normal, right? Always go back, what is the normal physiology of ADH? Normal physiology of ADH is to bring that water back into the blood by putting on those aquaporin channels, right? But since you don't have ADH, when you don't have ADH, you cannot bring back that water. When you cannot bring the water back into the bloodstream, you are going to cause increase in serum osmolality. Simple as that, right? Okay, now ADH levels, for sure, we said it is decreased here. Here, it has to be high, or it could be normal, but high is the more appropriate way because there are a lot of ADH here, but they're resistant, meaning it's not working on its receptors. Now, water restriction test. With 2-3 hours, you try to take no water for 2-3 hours, followed by testing. What do you see change? There is no change or slight increase in urine osmolality. And why there's no change? Because no matter what you do, you don't have the ADH. Simple as that. You don't have the lesser nucleus that produces ADH. So there's going to be no change. With the ADH resistance, again, there's going to be no change because no matter how much ADH you're going to put in, the receptor is not working, so you will have no change. Now, with the administration of desmopressin, this is the important thing and very differentiating point in both of these, uh, that if you were to give desmopressin, now what's going to happen with a central DI, which had a low ADH, you give ADH from outside, the patient is going to feel better. Everything will just go in. He's going to be better, right? Because you're giving ADH, you don't have any receptor problem. ADH is going to work, and all good. But with the resistance, no matter how much ADH you give from outside, it's not going to work. So you have to manage the underlying cause. What is the underlying cause? Lithium. Stop lithium. Demeucocycline. Treat hypercalcemia. Treat hypokalemia. Okay. Put the patient on low solute diet. Hydrochlorothiazides, amiloride, or endomethacin. All of them are the treatment for nephrogenic. Okay, normally there's another graph. Let's just actually draw that graph quickly. So you have urine osmolality on this side, and your serum osmolality here. With the serum osmolality, 290 is about like normal, right? So the graph is going to be, for example, let's change color here. So primary polydipsia, urine osmolality, let's say, starts at 500, and then it goes about 290, then goes up when you administer that desmopressin, so DDAVP. Okay. And with the so there are two nephrogenic. Okay, one important thing again is there are two types of nephrogenic DI. Either one is complete and one is partial. With the complete, no matter how much DDAVP or anything here you do, nothing is going to work. It's called complete DI. But you could do this to have a symptomatic treatment, right? So it's called nephrogenic DI complete. With a partial nephrogenic DI, if you were to give some ADH from outside, it might work a little bit. So let's just, a little bit doesn't look like this. So I'm just going to do it like this here. Okay. Okay. So this was normal. So let me just go back and tell you again. Normally, you have a patient here, total normal patient, having 500 urinary osmolality, but as soon as you give outside from desmopressin from outside, they will cause increase in the urine osmolality. Okay, because they're trying to retrieve back that free water, and that is the DDAVP administration. Okay, this is a graph. Okay, this is normal. This is complete complete nephrogenic DI, in which no matter how much DDAVP you give, nothing is going to work. With a partial, this is partial nephrogenic DI. There is some change when you get from outside. But more importantly, what is important here is that you have a central DI, because when you give so it was pretty low urine osmolality, but as soon as you give DDAVP, it's going to rise automatically way too high to normal, all the way to normal. So you can just think about that as a central DI, that there was a deficiency in DI, diabetes insipidus ADH secretion. Okay. Yeah, and that's pretty much the graph. You also have a graph for primary polydipsia. Let me just also do that. That's this simple like this, but because there is no connection to DDAVP, so it's just going to go higher and higher as the water level increase. Okay, so yeah, that's pretty much it. Let's just review this and move on to the next. Okay, let's review this part. Uh, Primary polydipsia, endocrine ADH, which is diabetes insipidus. All you will see is going to be your polyuria and polydipsia. Okay, and that so with the primary polydipsia, you're taking a lot of water, either psychiatric illness or third center illness. Because you're taking a lot of water, serum osmolality is going to be down. And if you were to do the restriction on water, you will increase your urine osmolality, and the treatment is going to be your water restriction. With a central DR, nephrogenic DI, with the central meaning from top, for example, hypothalamus or the ADA, anterior posterior pituitary, something is wrong. But the question arises if you, again, very high yield, that if you have a damage, anything below hypothalamus, you are going to cause transient DI, transient central DI. Why? Because ADH is produced from hypothalamus, so you will not be going into permanent DI. But if you knock out your hypothalamus, you're going into permanent DI, not transient, permanent DI. That's also a very high yield point. Okay. Other name for ADH, low ADH central or nephrogenic is going to be arginine, either arginine deficiency or arginine resistance. Okay, so with that, let's quickly look at both of these, central and nephrogenic. Central, again, low ADH resistance with the nephrogenic causes are high yield. Okay, with the ADH resistance, high yield, again, with the hereditary mutation of V2 receptors or drugs, lithium, demyclocycline, hypercalcemia, hypokalemia. They will both lead to increased level of serum osmolality. ADH is, again, a differentiating feature. With central, you have a low ADH. With nephrogenic, you have high ADH. That is why in central, you can treat it by giving ADH. And in nephrogenic, you don't give ADH from outside because there is resistance. So you treat the underlying cause and the other things. With the water restriction, there's no change. And desmopressin administration will significantly increase urine osmolality. That's high yield for central, but minimal change in urine osmolality with nephrogenic DI. Okay, and this is a pretty nice graph, although, yeah, if you take a look at it, I mean, if you understand it, the normal is this. When you give, this is normal urine osmolality 500. When you give outside, from outside, you give DDAVP, which is desmopressin, is going to increase urine osmolality, and also this is normal. So if this is normal, straight up here, if you give someone DDAVP, nothing changes. Is permanent nephrogenic DI, or not permanent, is called complete nephrogenic DI because nothing is changing. But if you were to give DDAVP, which is desmopressin, and it does change a little bit, that's just a partial nephrogenic. With primary polydipsia, it again has nothing to do with DDAVP, so it will just continue to move higher and higher. And just the one thing that will have the most effect when you administer DDAVP is going to be your central. So it's going pretty low, but as soon as you give DDAVP, is going to increase urine osmolality, which is also denoted right here. And in a graph, you will see it like this. Okay, and that is pretty much it for that primary polydipsia and diabetes insipidus. Moving on to the next one. But I guess before that, let's just take 5 minutes break. What do you guys say? Should we take 5 minutes break or? great. Okay, let's just take 5 minutes break and we'll be back at 45. So let me just write x 45. X 45. Okay, I'm back. Okay, yeah. Very nice, Dr. Samarine. Very good. So basically, if you think about it here, we did where we talk about some here, it's treatment, right? So yeah, amiloride and domethacin, right? So amiloride is again, it's very right that it is a potassium sparing diuretic. Uh, so what it does, it's basically it inhibits the uptake of lithium. If you recall, go back to lithium. Uh, that this drug will inhibit the uptake of lithium. When you inhibit the uptake of lithium, more lithium is going to go out. The more lithium goes out, uh, the problem would be with the lithium specifically. Okay, with an endomethacin, and that's just one of the things, right? And we will see in pharmacology more about it. But with endomethacin, it's an NSAID, right? So it's going to inhibit that prostaglandins. So when you inhibit the prostaglandins, what they are going to do, the inhibition of prostaglandins in the renal medullary tubules, uh, they would lead to enhanced work of ADH, meaning they might, again, in some patients, they do increase the work of ADH on their receptors. So that is why nephrogenic, there is a resistance. If there is a mutation, nothing is going to work. With this, you have to just go ahead and treat the underlying cause if these are the underlying causes. Okay. Yeah, that's, and we will see that more in pharmacology. But good question, nice. With that, let's move on to the next part. Okay, here. Uh, okay, now let's talk about hypopituitarism. As the name suggests, hypopituitarism. There's the under secretion of pituitary hormones. Um, what are the factors? Why did this happen? Well, it could be a problem in hypothalamic diseases, for example, a mass lesion, radiation, infiltrative disease, pituitary surgery, pituitary disorder, for example, mass effect due to non-secreting pituitary adenoma, or craniopharyngiomas, or empty if you recall, the anterior pituitary was sitting on the sella turcica, that's the bone, right? If you have an empty cell, I mean, this whole thing is empty, there is no anterior pituitary, of course you are going to go into under secretion of pituitary hormones. Okay. Uh, High yield point is going to be Sheehan syndrome. Sheehan syndrome is an ischemic infarct of the pituitary following severe postpartum hemorrhage. Okay. So question is, why does this happen? Well, when you go into pregnancy, there is a pregnancy-induced pituitary growth, right? Because you need more and more hormones. The pituitary grows in pregnancy. When you grow in pregnancy, you need more blood. So while you're pregnant, you're giving more blood supply and everything. But when you are going into postpartum bleeding and hemorrhage, you are going into hypovolemia. You are going into hypoperfusion of this area, leading to ischemic infarct. Okay, let's read back this here. Pregnancy-induced pituitary growth occurred, which leads to increased susceptibility. They're susceptible to hypoperfusion. Usually presents with failure to lactate, amenorrhea, cold intolerance. Anterior pituitary hormones mainly affected. Why? Because posterior pituitary were coming from hypothalamus, right? Treatment is hormone replacement therapy. For example, you give glucocorticoids, you give thyroxine, sex steroids, human growth hormone. All of them can be given. Okay, with this, also let's talk about something. When we think about under secretion, right? Hyposecretion of hormones specifically. So we say, let's say ACTH is under secreted, let's say ACTH deficiency. it will lead to hypotension, weight loss, and hypoglycemia. Weight loss, hypoglycemia. And due to the fact that, can you recall which, where does the ACTH go and stimulate? Well, if you recall, if you're saying from the GFR, you're saying F and R, then you're right. They stimulate F and R. F making the cortisol and R making the androgens. So with the cortisol, because you cannot maintain the vessel, you cannot have the cortisol work on the vessels, you're going into hypotension because they're going to vasodilation, hypoglycemia because cortisol is also a glucocorticoid, remember? So, and weight loss is going to be there with ACTH deficiency. With gonadotrophins, let's say gonadotrophins, low gonadotrophins in women is going to cause amenorrhea, infertility, and in men it's going to cause loss of libido and again infertility, right? One high yield point is that you don't cause any of under secretion. So let me put it this way: symptoms of hypopituitarism arise when you have greater than 75% of pituitary parenchyma being lost. So you need to have about more than 75% of destruction of the pituitary in order for you to have symptoms, which are all of these and the ones that I mentioned. Okay. And yes, that's going to be pretty much all we have. Simple yet important. Let's take a look at now acromegaly. Well, acromegaly is all about excess growth hormone in adults, right? So if this is in adults, what about in children? If you have increased growth hormone in children, it's called gigantism, right? So in adults, we are talking about acromegaly, typically caused by pituitary adenoma. Okay, so pituitary adenoma, meaning this adenoma is, wait, one more thing here, very high yield. When you think about pituitary adenoma, the most common hormone they will secrete is the prolactin, most common hormone. But second to that, most common is going to be your growth hormone. Okay, so here, if you think about pituitary adenoma, we can say this adenoma is secreting growth hormone. And this growth hormone is just causing in adults acromegaly. And if it was a children, it would cause gigantism. Okay, with that, let's look at the findings. The findings are that you have large tongue with deep furrows, frontal bossing, high yield. Look at the frontal bossing. Look at the normal baseline picture. And look at with acromegaly, with growth, increasing growth hormone, the whole everything is almost changed here. Frontal bossing, coarsening of facial features, with aging, deep voice, diaphoresis, excess sweating, hypertrophic arthropathy, high yield. This hypertrophic arthropathy is basically your hypertrophy of articular cartilages, and that is going to cause in these patients arthralgias, high yield arthralgias, because the cartilage has gotten so bigger. You have hypertrophy of those articular cartilages that it causes now pain when they move, and also causing this arthralgias with osteoarthritis, right? So these two things with the hypertrophic arthropathy. Impaired glucose tolerance, because if you recall, growth hormone was counter-regulatory hormone to the insulin, right? All they wanted, these counter-regulatory hormones, they wanted to increase glucose within the bloodstream. So that is why they will have a lot of glucose, causing insulin resistance, hypertension, left ventricular hypertrophy, and you have heart failure with preserved ejection fraction and this is the most common cause of death. So these patients go into heart failure, but with preserved ejection fraction, and this is going to be the most common cause of death in these patients. Now, if you think about how this happened, it's that when you're growing everything with this growth hormone, you're also growing your cardiac muscle, right? When your cardiac muscle is growing, it's going to cause left ventricular hypertrophy, which is mentioned right there, right? And after left ventricular hypertrophy, eventually they will go into heart failure, right? Uh, Cardiomegaly, important thing they will mention in the findings. The patient went into cardiomegaly. With the cardiomegaly, the PMI, the maximum impulse is going to be into the axilla. The maximum impulse is going to be deranged from the fifth intercostal all the way going to the axilla. Okay, and that's the cardiomegaly. Okay, what else we might see with this? So high yield point, which I don't know why they haven't mentioned, but it's going to be that these patients, they will classically say, hey doc, my ring size does not fit me anymore. My shoe size does not fit me anymore. Okay, so increase in hat size, increase in ring size, increase in shoe size. Okay, or in females, they can come with carpal tunnel syndrome, okay, or OSA, obstructive sleep apnea, as well, OSA, because you have growth of the tissue so much that it is going into OSA and it's going to carpal tunnel syndrome. Okay. So with that, let's just look at one last thing here. When you think about growth hormone axis in adults, you're gonna think of growth of everything. So growth of visceral organs, so all the organs growth, enlargement of all soft tissue. Uh, what are the soft tissues? For example, bone, cartilage, everything is going to be increased in size. Okay. Uh, so let's look at here now. The second point is increase in growth hormone in children is called gigantism. Now in gigantism, you see increase in linear bone growth due to unfused epiphysis or epiphyseal plates are not fused. So their growth, gigantism people, they will have height they will be very tall, large hand, big guys, right? Big people. That's the gigantism. Because why? Because their linear growth has been increased because they did not fuse their epiphyseal plate with the adults. Because the epiphyseal plates are fused, all they are going to grow is their organs, visceral organs and soft tissues. Well, in gigantism, you're growing the linear bones. Okay, that's very important. Now, acromegaly in adults and gigantism in juniors, that's a mnemonic. Okay, and then let's talk about diagnosis. How do you diagnose this? Oh, well, diagnosis is simple. If you recall, we said the growth hormone, to diagnose growth hormone, has a direct function of only one thing, and that was on adipocytes, right? And secondly, it was just going on liver, causing release of IGF. So that is why we check for the level of IGF, which is insulin-like growth factor, because this is the main guy who does all the job. Okay, so here, increase in IGF-1, its growth hormone levels, unreliable as they fluctuate throughout the day. Okay, that is why you check for IGF-1. Okay, failure to suppress growth hormone following oral glucose tolerance tests like OGTT, pituitary mass seen on brain MRI. Okay, so again, how do we diagnose? We diagnose it by looking at increased level of IGFs. Okay, and we diagnose by failure to suppress by giving oral glucose tolerance test. Okay, or we actually, when we looked in the brain MRI, we saw the proper pituitary mass, so we can then say, okay, we have diagnosed the problem. One important thing, which again, I don't know why I didn't mention, is called prolactin. So if you recall, whenever you have the growth hormone is going to increase prolactin secretion. You increase growth hormone, you increase prolactin. Simple as that, right? So when you have increase in growth hormone, that should give you increase in prolactin. So you should also see increase in prolactin levels. Okay. And let's look at now with that, let's look at treatment. In treatment, we have pituitary adenoma resection. If we see there is a problem in the on the MRI, there is a pituitary adenoma, we just go with the resection of that. Simple. If not cured, okay, treat with octreotide, which is somatostatin. Anything with the statin, you can say it's the inhibition. Okay, what is inhibiting here? Somatostatin. So it's inhibiting somato, which is again, if you recall, somatomidin, somatostatin, all of them are growth hormones, and somatomidin being IGF-1. And you can go back to physiology, see that one. But somatostatin, which is octreotide analog, can be given as a treatment. Pegvisomant, which is growth hormone receptor antagonist, can be given, or dopamine agonist, for example, cabergoline. Again, what are you trying to do with dopamine agonist? Well, you're trying to inhibit the release of prolactin and in turn release of growth hormone. So let me just do it here. I'll write this down here. So octreotide, your octreotide and dopamine agonists both are going to inhibit the growth hormone release from anterior pituitary, okay, essentially leading to decreased GH and decreasing in IGF-1, which is insulin growth factor 1. But also on top of that, because you're inhibiting the release from anterior pituitary, if there is a mass, you're decreasing the adenoma mass, adenoma size, right? Because you're decreasing secretion of whatever it's producing, so for sure it's going to decrease the size. Well, on the other hand, this pegvisomant is going to inhibit IGF release from liver. Why? Because pegvisomant is growth hormone receptor antagonist, and again, recall, growth hormone works on liver. So there's a receptor that works on. So you try to block this receptor, you are going to have growth hormone, but what you're not going to have is IGF-1. That's exactly with pegvisomant, that it's going to inhibit IGF-1 release from liver. Simple. Okay. But if again, first of all, if nothing goes out, then you can go for it's called transphenoidal resection of pituitary gland. So transphenoidal resection of pituitary, that's one thing. Or second, these are all the meds you can give. The third thing is that you can give radiotherapy, which is radiation basically. Okay. Okay, one last point is you have to screen these patients for colonic neoplasm. So screen these patients for colonic neoplasms with colonoscopy. So with these patients, you got to do colonoscopy. This is acromegaly is associated with MEN1. Okay, and we will see what MEN1 is later on. Okay, and that's going to be all for acromegaly. Let's just quickly review this and move on to the next part. Acromegaly, first of all, is hyperpituitarism. Hyperpituitarism, everything is low. Under secretion, could be disease of hypothalamus, could be surgery to pituitary or any pituitary disorders. For example, there's an adenoma or craniopharyngioma, or there's just empty sella, or high yield Sheehan syndrome. Sheehan syndrome is that it did grow in pregnancy, but now because we lost so much blood that it needs more blood, and now we don't have the blood, so it's susceptible to hyperperfusion, leading to ischemic infarct of the pituitary. Okay, and then it's going to cause failure to lactate, amenorrhea, colon intolerance. So postpartum women with like impaired to lactate, with amenorrhea, with cold intolerance, uh, all the anterior pituitary mostly affected. Treatment is you got to give uh, hormone replacement of whatever is damaged. Then you have acromegaly, which is excess growth hormone in adults. Findings are large tongue, coarsening of facial features, deep voice diaphoresis, with arthropathy leading to osteoporosis and leading to arthralgias, um, increase in head size, increase in ring size, increase in shoe size, all are uh, findings. And then you have this, there is an impaired glucose tolerance leading to insulin resistance, leading to secondary diabetes mellitus, right? Hypertension, high yield is because you're growing the cardiac tissue, leading to left ventricular hypertrophy, causing heart failure, cardiomegaly, basically, all of that, right? Diagnosed by increase in IGF because growth hormone fluctuates. So you can look at increased level of IGFs. Okay, with normally glucose should suppress the growth hormone, but if the glucose does not suppress the growth hormone, then you can also think about uh, acromegaly or increase in growth hormone, or you could actually see the pituitary mass on the MRI. If you do the MRI, you see the pituitary mass. Treatment is, if you have the pituitary mass, do a transsphenoidal resection of that tumor, okay, or give octreotide somatostatin analog or dopamine agonist, both are going to inhibit the growth hormone from the anterior pituitary. Well, pegvisomant, which is a growth hormone receptor antagonist, it will lead to decreased level of IGF-1. And that is going to be all for acromegaly. So let's take a look at one thing for this was all about high level of ADH, right? And in children, you were thinking. I mean, there is a increase in linear bone growth, but what about we have a low growth hormone? Well, again, it's different in children and different in adults. In children, if you have a low growth hormone or growth hormone deficiency, again, simple thing, decrease in linear growth. With decrease in linear growth, we are going into short stature and dwarfism. Short stature, dwarfism. Okay, in children and adults, we have we will have a decrease in lean muscle mass, central obesity, increase in cholesterol, LDL and cholesterol levels, uh, and they will have, essentially they will have fewer signs and symptoms because other counter-regulatory hormones like glucagon, cortisol, catecholamines, and all these are going to take over and do the job. Okay, so but what you will see is decreased muscle mass, central obesity, and increase in LDL cholesterol levels. And that is all for growth hormone. Okay, let's take 2 minutes of break. I'm just going to stretch and I'll be back in 2 minutes. Okay, let's get back. Okay, now let's talk about hypothyroid and hyperthyroidism. Um, Very important, okay? Hypo and hyper. So, as a mnemonic, you can just think of everything with hypothyroidism. Let's just put it here. With hypo, everything is going to be low. There are some exceptions, but just uh, mostly with hypo, everything is low. Everything low. And with hyper, everything high. But there are some exceptions, okay? And we will take a look at that as well. So let's just take a look at now each one of the details. Now, metabolically, with hypo, these patients are going into cold intolerance, okay? And the way you think about cold is if you go low in temperature, you are going into cold. So I said everything low, low temperature, cold, cold intolerance, okay? Um, Decrease in sweating. Weight gain is an exception. So weight is an exception, which is high. Okay. And decreasing in basal metabolic weight gain is due to the fact that you have a decrease in basal metabolic rate, so BMR. Uh, that decreases the calorie genesis. Okay. Uh, and then hyponatremia, low in sodium, uh, leads to decrease free water clearance. Okay, with the metabolic on the hyper, we have heat intolerance, we have increased sweating, we have weight loss. So exception here is weight loss because of the fact that you're increasing the synthesis of sodium, potassium, ATPase. That increases the basal metabolic rate. Again, the BMR is increasing caloriogenesis. Okay. Uh, that's with the metabolic. Now, with the skin and hair, we have a dry, cool skin due to decrease in blood flow. Coarse brittle hairs, high heel, coarse brittle hairs, diffuse alopecia, brittle nails, puffy faces, high yield generalized non-pitting edema, mixed edema due to increase in gags, uh, uh, glycoaminoglycans in intestinal, my bad, interstitial spaces, increase in gags in interstitial spaces, increased level of osmotic pressure, water retention. That's the whole point we're trying to figure out. Water retention. Okay. On the other hand, hyper is going to give you warm, moist skin due to vasodilation, fine hairs, onycholysis, which is picture A. Where's picture A now? Okay, here. Okay, this is and then you have the pre-tibial myxedema and the Graves' disease. Okay, what else might be there? Okay, something that they haven't mentioned, which is also very high yield. It's about when you talk about increase in metabolic rate, you also have to think about there's increased metabolic rate and direct vasodilation. So let's just say increase in vasodilation. It might come up, but I'm just going to write it here. Increased vasodilation that will lead to decrease in SVR, uh, which is systemic vascular resistance, which is also known as TPR, right? Or peripheral resistance. So when you increase vasodilation, you're decreasing the TPR, and that is going to cause decrease in diastolic blood pressure. Important. And we will talk about that in a bit. But then you have this ocular findings. Well, the ocular, you have again high yield preorbital edema. Let's take a look at picture see preorbital edema. Okay. Uh, and in hyper, you will see ophthalmopathy and Graves' disease, including you will have periorbital, my bad, not pre, but periorbital edema, and high yield is exophthalmos for the Graves' disease. Graves' disease, exophthalmos. Lead lag retractions will be seen because of increase in sympathetic stimulation of the superior tarsal muscles. Okay. Uh, and since we are talking about here the Graves' disease, one of the things that we can do to treat this problem, which is the exophthalmos, uh, and that is going to be uh, your treatment of the Graves' disease by giving glucocorticoids, which essentially decreases inflammation, which would decrease the exophthalmos or the Graves' disease ophthalmopathy. Okay. The next one here we have is the GI, which is for constipation, decrease in GI motility, decrease in appetite. So everything is low if you think, right? Decrease in GI motility leading to constipation, decrease in appetite. With everything being high, hyperdefecation leading to diarrhea, increased GI motility leading to diarrhea, increase in appetite. Then you have MSK, musculoskeletal. Musculoskeletal, you have hypothyroid myopathy, which is proximal weakness. That proximal weakness causing increase in CK levels. Okay, high yield. You don't think about proximal muscle weakness with hypothyroid, but this is important because if you think about the other way, let's look at this hyper one. This is thyrotoxic myopathy. Again, you have proximal weakness, but a normal CK. So both are giving you proximal weakness, so proximal muscle weakness, but one is giving you the normal CK, another one is giving you a high CK. Okay. But there are also a couple more differentials that go with high CK, proximal muscle weakness. What are those? Well, those are going to be something, if you can recall, polymyositis, dermatomyositis if there's skin involved, right? But also statins, if you think about it, statins giving you proximal muscle weakness, right? Which would also increase cyclic, not cyclic, but CK, creatine kinase. Okay. With the normal CK, there are also differential diagnoses. What are the differential diagnoses with the normal CK but proximal weakness? You have glucocorticoid muscle myopathy. So due to the fact that someone is taking glucocorticoid, it leads to myopathy. The second thing is your polymyalgia rheumatica. Then again, you also have thyrotoxic myopathy as well. And these are the things for differentials when you think about proximal weakness within high yield. Okay, because only with one thing you can right away tell where's the problem. So if you have a proximal weakness with increased CK, what do you want to do? You want to check for TSH testing. So next best step would be, if you see hypothyroidism, you want to check for TSH testing to confirm the diagnosis. But in other way, you can also see all of this in polymyositis, dermatomyositis, or statin therapy. So high yield. And with this polymyositis, polymyalgia rheumatica, and glucocorticoid induced myopathy can lead to normal CK levels. Okay, moving on with the carpal tunnel syndrome, myoedema, high yield. Myoedema is again very high yield. Okay, it's a small bump arising on the surface of the muscle when struck with a hammer. You struck a small muscle with a hammer, there's a myoedema, bump comes on it. High yield for hypothyroidism, okay? And for the hyperthyroidism, we have osteoporosis. Increased fracture rate, because T3 stimulates the osteoclastic activity, differentiation, and causes increased bone resorption, that leads to osteoporosis, and release of calcium may affect the osteoblasts. Again, what did we talk about? We said this is again very high yield, so I'm just gonna talk about a little bit of this. So we said with increase in thyroid, we are going to cause osteoporosis, increase in fracture rate. Okay, increase in fracture rate. All is everything due to the fact that the T3 is stimulating the osteoclast differentiation, and that is going to essentially cause increase in bone resorption. When you increase the bone resorption, you are going to release calcium, hypercalcemia. That's one thing. And it's going, because when you are reabsorbing the bone, and it's going to cause osteoporosis, which leads to increase in fracture rate, all due to the fact that you have increase in T3, which is directly stimulating osteoclast differentiation. Okay. Reproductive high yield. Here we will have AUB, abnormal uterine bleeding, decreased libido, infertility. Okay. Again, you will also see AUB in the hyperthyroid. You will see infertility. You will see decreased libido. The only extra thing that you will see in hyperthyroid is gynecomastia. Other than that, the whole reproduction is all same, no matter you're in hypo or hyper. Okay. And then one thing which is different, which I don't know why they haven't mentioned, is with the hyper, you will see oligomenorrhea. Okay, and with hyper, you will see oligo. With hyper, you will see increase in menstrual flow. Okay, that's reproductive. And the next one you have is neuropsychiatric. Neuropsychiatric, you have hypoactivity, lethargy, fatigue, weakness, depressed mood, decrease in reflexes, delayed slow reflexes. So important. What is important here? Low reflexes is high yield. Why is this high yield? Because the other one is going to give you, increased reflexes, which are brisk reflexes. Here you have low or decreased, delayed or slow reflexing. Again, with this, you have hypoactivity. These patients will have hyperactivity, restlessness. They're not getting tired no matter what they're doing. These hypo are going into lethargy. They're always tired. There's fatigue in hypo. There's weakness in hypo. In the hyper, restlessness, anxiety, insomnia. They're not sleeping, but still they're like, hey, we're not tired. Restlessness is there. Okay. But importantly, fine tremors because of increase in beta-energic activity. You have fine tremors. Okay. In the cardiovascular, we will see bradycardia, dyspnea, and exertion. Why? Because you are decreasing cardiac output. That is why you will have dyspnea, shortness of breath on exertion. You're trying to exert, but you don't have a cardiac output. You are going into shortness of breath, SOB, dyspnea, bradycardia. While on the other hand, not techie, but hyperthyroid is going to give you tachycardia, high yield, palpitation, with tachy leading to palpitation, dyspnea, shortness of breath, arrhythmias. Okay, arrhythmias, for example, AFib. Okay, AFib. What else? Chest pain, systolic hypertension due to increased number and sensitivity of beta-adrenergic receptors. Okay. And you will have increased expression of the cardiac sarcolemmal ATPase, decreased expression of phospholamban. Okay, one important point that they have mentioned, which you need to know, is increased in systolic hypertension, right? Why specifically systolic hypertension, we should say, right? Why? Because if you recall, we talked about how in hyperthyroidism, you're causing increase in the vasodilation, which will decrease the systemic vascular resistance, which will decrease the diastolic blood pressure. When you're decreasing the diastolic blood pressure, so let's just say when you're decreasing diastolic blood pressure and you are essentially causing increase in systolic hypertension. So if you, let's just write it here, decrease systolic, increase in systolic, decrease in diastolic, the pulse pressure will also go high. So increase in pulse pressure. Okay. And what is the pulse pressure? Pulse pressure is difference between your systolic minus the diastolic. So here the difference is a lot because you're decreasing one thing, the other thing you're increasing. It's causing increase in pulse pressure. Okay. Other than that, tachycardia. So you will see a patient with, so let's just put it this way, thyroid heart. Let me erase this part and right here, the cardiovascular things. So thyroid hormone directly affects on the heart and blood vessels. So heart plus vessels. So the things they do is increase in vasodilation, which leads to decreased SVR, which leads to decreased diastolic blood pressure. We talked about it. Second thing it would do is increase contractility. When you increase contractility, now you're going to cause a couple things. You're causing increase in ejection fraction, increase in cardiac output, and this is going to cause high output heart failure. So with thyrotoxicosis is one of the cause of high output cardiac failure. Okay, with increased contractility, you're causing increase in myocardial oxygen demand. Okay, you're also causing increase in pulmonary artery pressure and high yield. Because of one thing about increase in myocardial oxygen demand, that you're causing increase in demand for oxygen from the cardiac muscle, there is a propensity that you can go into angina, okay, with thyrotoxicosis. And lastly, important factor is increased stroke cause. Increase in, not stroke cause, but increase in stroke volume. We're talking about contractility on the heart. So increase in stroke volume, which will lead to increase in systolic blood pressure again, which we talked about here. Where is it? Systolic hypertension. And that was due to the fact that you increasing cardiac output, increasing ejection fraction, increasing stroke volume, increasing in systolic blood pressure, while not maintaining, but decreasing diastolic, eventually increasing your pulse pressure. Okay, I hope this makes sense. If it does not make sense, you need to go back to cardiology. Okay, what else that could be an important point here? Okay, hypertension. Okay, HDN. HDN is due to the fact that you have increase in PVR. So HDN is caused, although if you look here, you have bradycardia, right? High yield, bradycardia, low pulse, but you will see hypertension even in your hypothyroidism, but you also see hypertension in hyperthyroidism, but the factors are totally different. Okay. What else we can think of? Okay, yeah, that's pretty much it for the cardiovascular. Now let's take a look at labs. In the labs, what we will see is labs, you have increase in TSH. So first of all, you know that you have, this is hypothyroidism, right? With hypothyroid, you will have increase in TSH because they want to stimulate the thyroid hormones, so they all send in TSH. But you still have decrease in T4. Why aren't we talking about T3? Because T3 levels fluctuate. If you look here, we are not talking about an hypothyroidism T3, but here we do see T3 there. But we don't look at T3 much. We look at T4, TSH more. Why? Because T3, let me write it down, T3 high yield, T3 levels fluctuate, okay? Because it is mainly produced when you convert T4 into T3, so you don't know how much T3 you're going to produce because it all depends upon what T4. So we say, hey, why not we just skip that and let's look at T4. So that is why we only look at T4, because T3 levels again fluctuate. So it could be normal or decrease. So high yield is They will try to mess you up by giving you T3 normal level, T3 normal, and you'll be like, hey, T3 is the main guy, right? If you recall, T3 was the main thing for thyroid to for its own actions, right? The more active molecule, T3. And now when in the labs they say, hey, T3 is normal, and then you say, oops, it can be hypothyroid because T3 is normal, but no, they're trying to mess you up. T3, don't even look at it because these levels fluctuate. So this does not tell us if the patient is in hypothyroid or hyperthyroid. All you want to look for is TSH and T4. Hope it makes sense. And thank me later for it. But what else? Okay, one also important point is going to be your hypercholesterolemia. Well, hypercholesterolemia, you have again, simple thing that you have increased level of cholesterol. Why? Because decrease LDL receptor expression. So again, this is liver. Here is your LDL receptors that go on the liver. So when you decrease the expression of these receptors, normally what's happening is you have these LDL receptors, more and more LDL come from the bloodstream, go into the liver, taken up by the liver. Now, when you don't have this, when you knock these receptors out, when you don't have the receptors on the cell surface, the LDL is not going to go. When the LDL doesn't go, it stays in the blood, leading to increase in LDL or increase in cholesterol levels within the blood, leading to hypercholesterolemia. Okay. Other than that, what else we might see with it? That is going to be your not only hypercholesterolemia, but increase in total cholesterol levels, increase in LDL levels, increase in triglyceride levels, and these all things are essentially the cause of what? The increase. So hypothyroidism will increase the risk of cardiovascular disease or coronary artery disease. Okay, because of all that hypercholesterolemia. And lastly, one important thing is hyponatremia. With this, you will see hypo. Remember, we're talking about labs here. Hyponatremia. You will see with this low thyroid. With that, also labs, you will see something, my bad, not decrease, but increase in CK. We did talk about it. Increase in CK. But on top of that, we will see one more thing called anemia. And I think they have mentioned up top, but here, anemia, which side of anemia? It could be normocytic or macrocytic. Normal or macrocytic anemia. Okay. We did talk about how we would have increase in LDL, but why would we have increase in triglycerides? It is due to the fact that there is, with hypothyroid, there is a decreased expression. Hypo means low, like everything is low, right? So there is a decreased expression of what? LPL, lipoprotein lipases. When you decrease the LPL levels, you are going to cause increase in triglyceride levels. Okay. Let's compare this with a hyperthyroid. You have a low TSH, simple, high T4, simple, and you also have opposite of that cholesterol. So you have a low LDL, low HDL, low total cholesterol, known as all of this is hypocholesterolemia, right? But there's going to be one thing more, which is going to be hyperglycemia. Okay. And that is going to be pretty much what we have for this. Okay, let's just mention one thing here. T4 for neuropsychiatric, meaning for the brain development. Okay, T4 is essential. T4 is essential for brain development and myelination during your earlier life. So essential for brain plus myelin development. Okay, T4. So if you have a deficiency in T4 in a child, you will be going into irreversible intellectual disability, and we will see that in pathology. Okay, and let's just talk about the whole thing and move on to the next. All right, so let's revise this part. Okay, hypo and hyper, right? Hypo, everything is low except the weight, except the weight gaining, except the menstrual flow, and except the water retention. Everything is low. Cold intolerance, decreased sweating, decrease in basal metabolic rate. And why do we have basal very high yield? Is when we put on these sodium potassium ATPase, and normally you might ask, where does these work? So if you recall any action potential, and let's say in the skeletal muscle, you have an action potential. That action potential, at the end of that action potential, what do you need? You need a sodium potassium ATPase to throw back the levels. So for example, if you have to get the sodium out of the cell and put the potassium back in, that is the sodium potassium ATPase, and it requires ADP. When you require ADP, you are using energy, and that energy is your caloriogenesis. You have to form energy in order to use it, right? So when you increase your sodium potassium ATPase channels, you're increasing high yield, you're increasing basal metabolic rate, which is at the resting point. Whatever energy or whatever calorie that you are utilizing, that is going to be your due to the fact that you have whatever sodium potassium ATPase you have, because they're requiring active energy. Okay, so with this, just remember that you have a decrease in basal metabolic rate because in hypothyroidism, you are decreasing your sodium potassium ATPase channels, leading to decrease in basal metabolic rate. With hyperthyroidism, you're increasing sodium potassium ATPase channels, increasing basal metabolic rate. And because you're increasing, when you increase this ATP, you are going to go into there's going to be heat formation, so you're going to sweating, increase in sweating. Okay, weight loss is also there. One thing important with the weight loss is this is going to be without decrease in appetite. So you will have weight loss, but if you look at appetite, where's GI? Let's look at GI. When you look at appetite, it's high, and the patient is going to do weight loss. Okay, very high yield, and this is because, again, the same point that I'm mentioning, that you have increased your basal metabolic rate. Normally, you needed 2,000 calories. Now your body needs 5,000 calories. All you're taking in with increased appetite even is, let's say, 3,500 calories. Still, you're losing 1,500 calories. You are going into weight loss. Simple as that, right? A very high yield point. Increase appetite, but weight loss with increase in basal metabolic rate. High yield or the skin hair findings, although they look very low yield, but very high yield, because every time they define this: dry, cool skin, coarse, brittle hairs, brittle nails, puffy face, generalized non-pitting edema, and here you have warm, moist skin, fine hairs, and pre-tebal mixed edema. With a GI, high yield, simple constipation, decreased appetite, diarrhea, increased appetite, musculoskeletals, proximal weakness with increase in CP, not CP, CK, carpal tunnel syndrome, myoedema. High yield is myoedema, which is a bump which comes up on the surface of muscle when you struck the muscle by a hammer. Okay, thyrotoxic myopathy with normal CK, high yield. High yield again is osteoporosis, fracture rate because of T3 stimulating the osteoclast. High calcium will be there. Hypercalcemia will be seen. Reproductive, AUB, both will have decreased libido, decreased infertility, decreased libido, AUB, but gynecomastia, oligomenorrhea with increase in menstrual flow with hypothyroidism. Neuropsychiatric, T4 is essential for it because T4 is more active. Not active, but T4 is essential because as a child, it needs brain development and myelination by the T4. Okay, with this, all you get is with hypoactivity, lethargy, decreased reflexes, high yield, delayed, slow relaxing of reflexes. Okay, one high yield is going to be exact wording, which is when you say decreased reflexes, you say delayed relaxation phase of DTRs. Okay, let me just write this down. Okay, decreased relaxation phase of your deep tendon reflexes. Okay, uh, and it is delayed. Why is it delayed? Because due to decreased uptake of calcium from SR. So reflexes are delayed. Why? Because there is decreased uptake of calcium, and calcium comes from SR, sarcoplasmic reticulum. Okay, and with the other one, hyper is the guy who's going to be hyperactive, not resting, restlessness, anxiety, insomnia, can't even sleep, fine tremors, high yield. Why is that? Because hyperthyroid is going to increase on the vessels. It's going to increase beta adrenergic receptors. So more and more epinephrine catecholamines can work on it, and that's going to give you fine tremors. Okay, and that's why you can treat this by giving beta blocker, propranolol. Okay, specifically for these fine tremors, because nothing else would. And beta blockers would because you're trying to block these receptors, and it's going to work out. Increase in refluxes, which is the brisk. Okay, with the cardiovascular, again, you're going into a bradycardia, but hypertension will be seen. Here you have tachycardia with systolic hypertension and diastolic blood pressure being low, and that is essentially going to cause increase in pulse pressure. Okay, you will have, again, same thing which you talk about up top right here, increased sensitivity and numbers of beta adrenergic receptors. So hyperthyroidism is increasing the numbers and sensitivity to the receptors of the beta adrenergic. So if epinephrine, cortisol, not cortisol, but epinephrine, norepinephrine works on it, it's going to have a more bigger action. Increased expression of corticolamine ATP as a decreased expression of phospholamban. Okay. Now labs, super high yield. How do you diagnose this, right? How do you diagnose this? Well, you will see increase in TSH simple, decrease T4 simple, but hyper cholesterolemia, everything high, LDL, triglyceride, cholesterol, everything high, with hyponatremia, with increase in CK and anemia. With the hyperthyroid, it's the opposite, low TSH. And I'm assuming that you right now you know already why would we have low TSH. If you don't go back to the physiology, and you will see the autoregulation, not autoregulation, but negative feedback. And that is why we have low TSH, because we have a lot of T4 here. We have a lot of T4, or you can say a lot of T3, but mainly look at T4. That's going to give a negative feedback, causing low TSH. Okay, hypocholesterolemia, opposite the other one. Okay, but here you're gonna have hyperglycemia. Okay, and that is going to be all for thyroid. So since we're just here, let's also talk about some treatments. The treatment for hypo is going to be, you gotta replace the thyroid hormone, right? Replace the thyroid hormone with what? With levothyroxine. Levothyroxine for life. Okay, but importantly, one high yield point is you got to increase the dosage in pregnancy. In pregnant patient, you got to increase the dosage, because if now you know you're looking after two individuals, not only one, right? So in pregnancy, since there is since if you that was just a mnemonic. But in metabolically, what in pregnancy is what's happening. If you recall back, we said in pregnancy you have increased level of the binding globulins. So here it's going to be the thyroid binding globulin increased. Okay, and when you increase the thyroid binding globulin, you will have low free thyroid hormone. So, but you need it for the brain development of the brain, and we said the myelin for the child. So that is why you increase the dosage. So no matter how much you increase this part, you will still have enough for the brain, for the fetal brain development, because the fetal brain depends on this, on the mother T3 or T4 levels. Okay, that's for the hypo. For the hyper, let's just write this hyper here. You can give PTU, propanol thioglycerol, You can give beta blocker propranolol, which provides the fastest relief of hyperthyroid signs symptoms, and also fine tremors, also treated with this, right? You could destroy the gland by giving radioiodine I-31, I-30, which destroys the thyroid, or you can just go for thyroidectomy. Okay, and that is going to be all for thyroid. Okay, with this, I guess let's call it a day. Okay, and we'll get back tomorrow and do the rest. Thank you so much, all. Thank you so much to all of you who joined, and have a great day, guys. You're all welcome, guys. Thank you so much for joining. Hope it helps. Hope it's making worth it. Just try to memorize these and the rest of the endocrinology, and it'll be great. Okay. Thank you. Thank you all.